Assalamu alaikum and welcome to another video of Learn with Laraib. Today we will continue learning ECG. In just 5 simple steps, you will be able to read ECG, and by the end of this video, you'll be able to spot things most people miss. Let's decode it step by step. So the first step is to check the calibration and the patient details. And before reading any ECG, make sure you confirm the patient name and date. Also, the speed should be 25 millimeters per second. Thus, one small square should be equal to 0.04 second, and the voltage should be such that 1 millivolt is represented by 10 millimeters. If you get this incorrect, your interpretation will be off as well. So coming to the heart rate, there are different methods for a regular rhythm and an irregular rhythm. For a regular rhythm, it is basically 300 divided by squares between R wave. That's the method we will be using. So let's look at this diagram. Each 1 millimeter box, that is a small box, represents 0.04 seconds. Now 25 millimeters will be equal to 1 second. When 25 small boxes are equals to 1 second, we calculate heart rate beats per minute. So 60 seconds will be equal to how many boxes? 1500 small boxes. So one large box is equal to 5 small boxes, as you can see on this diagram. So how many large boxes will be 1500 small boxes? The answer is 300 large squares. So 300 will then be divided by the large squares between R waves. So as you can see over here, there are 2 large boxes between the R waves. So 300 divided by 2, 150 beats per minute will be the rate. For irregular rhythm, check and count the QRS complexes in a 10-second rhythm strip and then multiply it by 6. It is as simple as that. Now coming on to rhythm, you have to check if it is regular or irregular. Now how do you do that? So check that every P wave is followed by a QRS wave and every QRS is preceded by a P wave. Now this would seem as the same statement, but what you have to check is there can be a P wave which does not have a following QRS. So let's suppose you have checked all of this and there is a QRS wave and it might not have a P wave. So you have to check both of them. Now moving on to step 4, we will do a quick access check. So you will look at the lead 1 and AVF. If both are positive, the axis will be normal. If lead 1 is positive and AVF is negative, it will be left axis deviation. For right axis deviation, lead 1 will be negative and AVF will be positive. The fifth and the final step is to look for the pathologies. Scan for chamber enlargements, look at P wave changes or QRS voltage changes. For conduction blocks, look at the intervals mainly, can be PR, QRS or QT interval. For ischemia and infarct, we have to look at ST, T waves and Q waves. So this was all for the 5 steps to read ECG. Now that you have mastered that, let's put it into action with the ECGs you'll actually see on exams. We're going to discuss the high yield ECGs, starting with atrial fibrillation. Now, what is atrial fibrillation? Atrial fibrillation is basically caused due to focal activation. Instead of SA node generating a pulse, a lot of areas in the atrium is generating a pulse, and there are multiple wavelets as shown in this diagram. So in AFib, there will mostly be an irregular RR interval and absent P wave. As you can see in this diagram shown over here, this is an ECG of AFib. There is an irregular RR interval. Now, most common co-occurrence with AFib is mitral stenosis, and these two can lead to an embolus or further thromboembolic events such as stroke. Therefore, whenever there's a patient of AFib and mitral stenosis, we are to start them on anticoagulants. The definitive treatment, however, is catheter ablation. This is the definite treatment for AFib as well as atrial flutter. We will be discussing atrial flutter next. Now, atrial flutter and sawtooth appearance are correlated. Whenever you see an ECG with sawtooth appearance, it is atrial flutter. So it is caused due to back-to-back atrial depolarization, and there is a loss of isoelectric baseline. The definite treatment for this is as for atrial fibrillation, which is catheter ablation. Now moving on to VFib. VFib is an erratic, no identifiable wave pattern on an ECG, as you can see in this diagram. One important point is that VFib should never be diagnosed on a 12-lead ECG. Always diagnose it through a rhythm strip. It is fatal if there is no immediate CPR or defib. Now moving on to another high yield concept, which is AV block, also commonly known as heart block. So it is when the conduction between atria and the ventricle is blocked. First degree is when there is a lesser block, and it is usually benign and asymptomatic. So what we see on ECG is that there is a prolongation of PR interval. As you can see on this diagram, the PR interval is increased. The normal is less than 200 milliseconds. If you know the normal, you will be able to identify the abnormality. Second degree heart block has two different types. The Mobitz type 1, also known as Van Quebec phenomenon, has a progressive PR prolongation along with beat drop. As you can see in this ECG, the PR interval will keep prolonging until there is a beat drop between that. That is second degree type 1 heart block. Now for type 2, it's a little different, that it is characterized by a dropped beat without progressive lengthening of PR interval. And this may progress into third degree heart block. As you can see in this diagram, there is a beat drop and you cannot identify a progressive PR interval, unlike in type 1 heart block. The treatment for type 2 second degree AV block can be pacemaker placement. Now for a third degree complete heart block, basically there is no conduction through AV node. The atria and ventricles are beating independently. However, the atrial rate is always greater than the ventricular rate in the third degree heart block. As you can see, they're beating independently. There will be independent waves. These are the R waves. They are independent of the P waves. There is no synchronization. And sometimes the atrial repolarization is visible on the ECG. One thing that is visible on physical examination is the pulsation in JVP, and you can see Canon A waves in the JVP graph. So before concluding AV block, I would like to add a point. If there is 3:1 of P to QRS, it will be Mobitz type 2. So this was all for AV block. Now we will be discussing electrolyte abnormalities, starting with hyperkalemia, that is when there is an excess of potassium ions. This is another high yield concept. So remember it with the mnemonic high K is equal to high T. So in ECG for hyperkalemia, we see T waves which are peaked The PR interval is prolonged and it is progressing into absent P wave. The QRS complex is degenerating to a sine wave. So this is the pattern observed on the ECG with hyperkalemia. As you can see, there is a broad degenerating QRS. There are almost absent P waves and tall T waves. Whenever there is a question which mentions blood transfusion or potassium sparing drugs, make sure you correlate it with hyperkalemia because potassium will be in excess. So the ECG, if it has some changes, check the changes. The answer might be hyperkalemia. Now moving on to hypokalemia. When we were doing our previous video, I said that the U wave is associated with hypokalemia by mentioning it as hypokalemia. There's another thing in which U wave appears. You have to answer that. So we can see an inverted T wave, as you can see in the ECG over here as well, and a U wave. There is sometime ST depression as well. So hypokalemia and hyperkalemia, hypo has a push effect and hyper has a pull effect. Pull effect means peaked T waves, push effect means that there is a T wave inversion. Whenever there is an MCQ mentioning a heart sinking along with low T waves, the answer is hypokalemia. Now, there are some other metabolic conditions such as hypercalcemia, hypocalcemia, hypoglycemia. We have discussed this already in the previous video on ECG. You can view that to check what happens to ECG in other metabolic conditions. Now we will move on to some less important conditions, and since they are very hard to remember, I will be showing you some animations and mnemonics for you to remember those. Fast but regular rhythm, normal P to QRS relationship. So always think, is this physiologic? Can be through exercise or fever, or pathologic. Treat the cause, not the ECG. Ventricular tachycardia is when there is a broad QRS with raised heart rate. So wide is equal to worry, and VTach is often life-threatening. It has a broad QRS and the monomorphic waveform looks uniform while the polymorphic looks like a torsades. Always assume VTach in broad complex tachycardia unless proven otherwise. SVT is like a loop in the atria or AV node, shooting impulses down rapidly. There is a narrow QRS with a high heart rate, very regular, often starts and stops suddenly. So nodal rhythm is when AV node takes up the charge. Refer to this image where the original singer has a P blocked and the backup singer, that is AV node, is taking the charge. In this, there is no visible P wave or it is inverted as shown in the ECG diagram, and there is a narrow QRS. Whenever you see a nodal rhythm, think digoxin toxicity, ischemia, or post surgery. Wolff-Parkinson-White syndrome is when there is an extra conduction pathway formed. It pre-excites the ventricles and is shown as delta wave on the ECG. D for danger and D for delta, remember it with this mnemonic. It also shows as short PR interval and wide QRS, as you can see in the ECG. It can produce very dangerous arrhythmias. Last but not the least, bifascular block is when there is a block in two conduction pathways and it is commonly shown as axis deviation. For example, left axis deviation in left anterior hemiblock. Trifascular block is when there is a combination of bifascular block and first degree heart block. Basically, all three conduction pathways are blocked. So this was all for today's video. Please don't forget to subscribe, like, and share. Thank you.